Thank you for joining me this afternoon for the daily update on COVID-19 and the emergency we continue to find ourselves in the state of Arkansas, and continuing to work with our various task forces and working groups on addressing both the economic needs in our state, but also the continuing health needs. And I want to applaud Dr. Nate Smith, Secretary Smith, and his team for their continued vigilance and hard work and extraordinarily long hours that they're putting in, both to do the testing, both to do the analysis and do the work with the different groups. And so I thank you, Secretary Smith. Yesterday, we reported that we had 2,227 cases in Arkansas. Today, we have an additional 49 cases in the state, which brings us to 2,276 cases. Of the 49 new cases, 13 of those are from Cummins prison system. In terms of hospitalizations, we've increased our hospitalizations from 86 to 97, and the deaths decreased from 43 to 42. And Dr. Smith will explain that, but I think there was a Missouri resident that was counted yesterday. In terms of the charts I want to look at, let's look at the same charts that we've been looking at. This is the number of new COVID-19 cases in Arkansas, and you can see that beginning in early April, we had the top designation on the white area for those that are in a congregate setting, which would be Cummins Prison. And you can see where that was yesterday with the spike of over 300 cases that day. Today we're down to the 49 area. And so you can see where the trend line is. You go to the next slide and you'll see the 7-day rolling average of COVID cases. Now this one excludes the correctional facilities. You can see the trend line, and then of course this is the number of cases. The trend line, the 7-day rolling average, is in the orange, and then the next one is everything, the trend line with all the cases combined. 7-day rolling average of the new COVID cases. You see the bar graph, and then you see the trend line in orange. And so that is a coverage of the cases. Before I recognize Dr. Smith, I wanted to make a couple of important announcements. First of all, I indicated that May 4th was the target date for lifting restrictions on some of our businesses and hospitals in Arkansas. If we meet certain target goals and we believe that we're on the right path to reducing the spread of the virus, I'm pleased to announce today that based upon the guidance of Dr. Smith and his team, that we are lifting the restriction on elective procedures in our hospitals in Arkansas and our clinics. And this will allow them to go back to business. It will allow them to, for everybody in Arkansas to have access to the more routine procedures that have been put off over the last 45 days. This lifting of restrictions on elective procedures will be effective April 27, which is next Monday. Now, that is earlier than what we expected, but we with our number of hospitalizations, with the limited spread across the state, we feel comfortable with that, and Dr. Smith will elaborate on some of the specific restrictions or requirements for the hospitals and clinics as they go back to these elective procedures, but there are certain requirements that go with that. The second part of the announcement, if you could go to the next chart, I want to make it clear the timeline for future decision points that lead up to May 4th. And first of all, I emphasize that May 4th is our target date for lifting some restrictions with the caveat that we continue to make progress on reducing community spread of COVID-19. That is our target date. We work hard toward it. We set our goals. And if we continue along the path that we need to do, then May 4th, we can look at lifting some restrictions. Now, we also, just like we did today on elective procedure, we want to set a timeline for decision announcements leading up to May 4th. And so the below decision announcements will indicate whether a May 4th opening will be allowed and any of the applicable restrictive guidelines. And so April 29th, which is next Wednesday, I believe it is, we'll have an announcement on a restaurant decision. It doesn't say whether that decision is going to be yes or no, but it says we will make a decision at that time and it will be applicable to a May 4. And so if we're on the right target date, then it's potential that May 4 will be an opportunity to go with some restrictions, of course, with in-service dining at some restaurants, and that announcement will be made next Wednesday. The next day, on April 30th, we'll have an announcement in regards to gyms, exercise facilities here in Arkansas. May 1, we'll have an announcement, a decision point in reference to beauty and barber salons, which everybody is anticipating, but we won't be in a position to make that announcement until May 1. And if we say yes to that with the conditions that we work, then it'll be effective for a May 4 target date. May 4, then, which is a Monday, we will make an announcement as to places of worship and larger venues in Arkansas that has a greater congregation of people. And so it's important that we do this sequentially. It's important that we do it in a way that we can measure. And so we're taking it very cautiously, but at the same time, we want to give those decision points that will be coming up in the near future in the coming weeks. With that, let me turn it over to Dr. Smith for his comments.
Thank you very much, Governor. I want to especially express my appreciation to the Governor for his disciplined and data-driven approach to rolling back these restrictions. Before I go over the numbers, I want to briefly talk about the directive, about the elective procedures. We're still finalizing some of that language, but that should go out either later today or tomorrow morning, and will not be effective, though, until Monday. This will be an incremental approach. We will start with day surgery, not people who are expected to spend the night in the hospital. These will be patients who are not as sick. They don't have a lot of underlying medical conditions. They will be required not to have had contact with a COVID-19 patient within the previous 14 days. They can't come in with symptoms consistent of COVID-19. Initially, we're going to encourage the facilities to start with a smaller volume and to build up and to make sure that they have adequate supplies of PPE and other measures in place to eliminate the risk or dramatically reduce the risk of spread of COVID-19 within their facilities. And probably most importantly, patients at this stage will require that they have been tested for COVID-19 within 48 hours of that surgical procedure to make these as safe as possible. Again, we'll have that directive out either later today or sometime tomorrow morning. Rural hospitals will be excluded. They were excluded from the restrictions, and they're also excluded from these restrictions as well. Wanted to go over the numbers from today in a little bit more detail. As the Governor mentioned, we did have 49 new cases, of which 13 were from the Cummins unit. So we're at a total of 2,276. Of those, 1,371 are active. We don't have any new counties. We have 97 currently hospitalized. We have 23 on a ventilator. That's 4 fewer than yesterday. As the Governor mentioned, we're down to 42 deaths, and that's because one was reclassified as a Missouri resident. We have 863 who have recovered. That's up 54 from yesterday. We have a total of 262 healthcare workers who have been infected, and of those, 148 have recovered. We had an increase in cases associated with nursing homes. We have 35 new cases associated with nursing homes, so we're at a total of 170, and we now have 31 facilities in which we have active investigations going on. The update on the Cummins unit, we did have a few more test positive, so we're at 681 inmates as of 10 p.m. last night, with 14 staff who have tested positive. Based on some of the testing that we received, we have decided, together with the Cummins unit, to go ahead and test additional barracks. So there will be additional testing done, and so it is possible, likely, that we will have additional cases added to the inmate total, and we're also testing additional staff. It's very important that we help the staff to know whether they are infected or not, both to protect themselves and their families and their communities, but also to protect the inmates. And as the governor mentioned, we are going to be providing guidance and directives to bring back these different areas, and we'll do this in a way that is thoughtful, careful, done in coordination with those industries, but also the timing will be based on what we're seeing with our numbers. So if you go out and throw a party this weekend and you get a bunch of people infected, our numbers go up, you'll ruin it for everyone. So let's continue to practice those physical distancing and other measures that have gotten us to where we are right now. Thank you.
Thank you, Dr. Smith. And if you could pull back up the slide on the decision points, I just want to emphasize that as we make these announcements and make these decisions, we have both the lead, of course, the Department of Health, in looking at the data and looking at where we are, also coordinating this with our economic recovery task force led by Stuart Walton, so that we have their input from industry as well, working on exactly what we could do on these announcements and decision points as they come up next week. And I want to also emphasize again and ask the people of Arkansas to be diligent, to make sure that we do what we need to do to protect ourselves and to protect others. We're on a good path, but you can see how quickly something can flare up. And we all want to make sure we're in this for the long haul and do a good job. And with that, I'll turn it over for questions.
How much of this have you coordinated with some of the neighboring states, or have you at all?
Good question, and the answer is I've been in regular communication with about all of the surrounding states, as well as with a particular group of 8 states that we have a lot in common with. And so we have discussed the commonality and where we're going with this, but you know, these decision points, announcement dates, you know, are not necessarily going to be lined up with specific points of other states. We're acting independently based upon the data that's here, even though we're learning a lot from best practices and some of the things that are happening in other states.
What's the directive from the health department on elective surgeries in terms of abortion? How's that going to?
Well, as the previous directives have been, they're not directed at any particular clinic. They're directed at any clinic that does elective procedures. And as you're very well aware, the 8th Circuit Court of Appeals issued the writ of mandamus overturning Judge Baker's temporary restraining order against our directive. And so the Department of Health will be enforcing that directive you know, for all the clinics that it would be applicable to, but the challenge was that the abortion clinic indicated they weren't going to follow that, and this allows them to be required to comply as well. In terms of how this impacts everyone, it's effective next Monday, and so all of the clinics involved will be impacted in the same way. And Dr. Smith, did you have anything you wanted to elaborate on there?
As with any other surgical center or hospital, they will be required to comply with all the conditions. We're taking an incremental approach to reintroducing these elective procedures, and so they'll have to meet all the criteria. As if our situation with the COVID-19 epidemic continues to improve, we'll allow more different types of procedures to be done on sicker patients who require longer hospital stays. But for this directive that will go out and be effective on Monday, they'll have to meet all those conditions, including making sure their patients are tested within 48 hours.
Yes.
Do you have a date in mind for announcing any restrictions lifted on the lodging industry?
On the lodging industry, the short answer is no. We're looking at our economic recovery group that's working with the lodging, the hospitality industry, and so they're looking at it, working with industry as well as our Department of Health. I'm trying to think what phase that comes in. Do you remember, Dr. Smith, on where that fits?
I don't recall that specifically being addressed except general travel.
And so in phase one, we still discourage discretionary travel. We're still trying to hold that down in phase one, and this is going to be a pressure point. It is going to be something we're going to have to make a decision on, because we have a national park, in Buffalo National River Park, and there's many that want to be able to come to that, but if you open that up, it has to be open nationally. And so that once again invites people from other states that are here, and that's what we've tried to diminish. And so we still have the restrictions on the lodging industry. We'll continue to examine that, but there has not been any specific time frame for a decision point on that.
In terms of testing people 48 hours ahead of procedures, are we to that point now where we're getting those results in that amount of time, or how will that work logistically if they don't have that result?
I do want Dr. Smith to comment on that, but I will say that the national commercial capacity for testing is increasing. In my survey of some hospitals yesterday, they were talking about a 24-hour turnaround, sometimes 36, 48 hours, but it's not the 4 to 5 day time frame that we had previously. That tells me they've really enhanced their capacity in the commercial labs. We're getting much quicker results in that. Dr. Smith?
Yes, some of the facilities that would be doing procedures, hospitals, actually have that capability in-house. And if they have one of the Abbott ID Now devices, for example, and they have cartridges, they can get a result in 15 minutes. Others have platforms that give answers within an hour or two, and so that's not a problem for them. For others that either have slower platforms or send out to commercial labs, that's why we've allowed up to 48 hours. It would be more ideal if it was done the same day as the procedure, but we've allowed that. Now, in terms of the commercial labs and their turnaround time, we were able to get over 1,000 tests done, mostly at the commercial lab from the Cummins unit, and we got those resulted within 24 hours. So there is a much faster turnaround times. They may have to, the hospitals and ambulatory surgical centers might have to do, make sure they've got good arrangements with a particular commercial lab that's got a good turnaround time. But once those are in place, they should be able to comply.
Can you clarify for us, will abortions resume on April 27th?
I think that will really depend on what the facility decides to do in terms of whether they can comply with those with the points in the directive. Of course, we've not applied our current restrictions to medical abortions, and so they, to my knowledge, have already been going on.
Is there a question remotely first, then we'll come back to the table?
Yeah, Governor, this is Andrew with AP. Wanted to clarify one thing on the schedule you put out. When you talk about places of worship and larger venues, just to understand, I guess, what limits are there on places of worship right now that would potentially be eased? And when you're talking about larger venues, what are the examples of what you're talking about when looking at that decision?
Well, larger venues would include sporting events. And so that is going to have to be a decision point in the future as well. But if you look on the White House Task Force for Coronavirus, you'll see in Phase 1 that they did include places of worship as a decision point there. And so that's the reason it's here. You ask about what is currently in place. We have guidelines that are in place, and to the credit of the faith-based community, they actually pay attention to those guidelines and they respect those. And so we take them very seriously. And so they're looking to us for additional guidelines as to how they can conduct their worship services consistent with public health. And we're going to be continuing to look at that. But that, when you bring in the larger venues, it brings in a greater risk. And we've seen that historically. And so we want to make sure we phase that in the right way with the right guidelines that we want to put into place. And the question right here.
On the Cummins unit, how many of those results have not yet been included in the state's overall total?
Most of them have. I can't guarantee that all of them have. Again, when they come in on a fax, it takes a while to deduplicate them, make sure we're not getting more than one on a. So we want good data integrity. But as you can see, there was a big drop off from yesterday. So I believe most of those are in. We will probably have some stragglers and probably some new results that are included tomorrow and perhaps the next day.
So when you look at the Health Department website, why does it still list 400 some cases in Lincoln County when you have 600 some cases at the prison?
Well, we have got different time frames and different. We want to make sure the data that goes up there is all correct data. So again, we've had a lot of results come in a very short period of time. So we are going to be a little bit behind on that, but we'll catch up.
Right here, then we'll go remotely again.
The directive on casinos expires April 30th. Will that be extended, or will casinos be opening after that?
We will be examining that, and that's not one of there's a number of things that you'll see that is not listed on the decision points, and that means we haven't got to it yet. And so that is something that we'll have to look at, but there's not a time frame for that decision point. And let's go remotely. Any question remotely?
Dr. Smith, the CDC, this is Drew Smith with the Times Record. The CDC recently announced an at-home test. Would that be a viable option for Arkansas, especially with these new restrictions being lifted on elective surgeries, that they would be able to be tested before going into surgery?
I believe you may be referring to the LabCorp self-collected at-home test, if that's correct. Yes, that received emergency use authorization from the FDA. That would be a great way to do that. Of course, that would need to be collected within 48 hours of the procedure. We haven't made any specific reference to that in our directives. I think that the venue, the facility that's doing the procedure would need to make sure they were comfortable with that. Obviously, if someone puts a swab in that that they hadn't actually swabbed in their nose, it would come back negative. If I were in that situation, I might feel more comfortable if we actually observed the specimen being collected and are sure that it was collected in a proper fashion. But we haven't made specific reference to that in our directive.
So some of the inmates at Cummins who are non-violent, non-sex offenders, and do you feel pretty good about their safety? The ones who are in the negative barracks now.
Well, I think the measures have been taken at Cummins in partnership with our team at the health department are designed to protect the safety of all the inmates. And again, knowing who's positive, who's negative, who's exposed, who's not, has given the critical pieces of information to help optimize that. Once we know those pieces of information, then we have the ability to limit the spread of COVID-19 in that facility, really even better than we do in the community, because the movements of individuals are restricted just by the nature of the facility.
Is being considered in other facilities, the non-violent, non-sex offenders. I just wondered if that would include those offenders at Cummins. Because they're actually might be more at risk than some of those in where the places where no infection has occurred.
I'm not, can you repeat the question?
So there are, the governor has asked the other facilities to look at their older nonviolent to see if they could be released. And so but Cummins wasn't really included in that list of other facilities?
Well, yeah, and maybe just briefly, we would not encourage release at a unit where there's an ongoing outbreak until that's under control. And in fact, we have asked to be notified if someone is being put out on parole and they've already tested positive, because it would not be a good thing if someone had tested positive, then were released, and for example, if they didn't have a place to stay, they went to a homeless shelter, well then you'd have a bunch more people exposed. So we would not want to do that in that setting.
Yes, ma'am.
The Institute for Health Metrics and Evaluation updated their report on their recommendations on when states should start lifting restrictions, and their recommendation for Arkansas was June 20th. What are your thoughts on that, and are you firm on that May 4th date?
Well, we're firm on the May 4th date as the target date. Now, we have to be on the right path. We have to be looking at the data and feel comfortable with the restrictions that we're putting in place. So, you're looking at a national model that looks at all the states. The states have to have some flexibility based upon the circumstances that we're in. I applaud Dr. Smith that he looks at the data and tries to make a decision that's a recommendation that's best for Arkansas. So I'm comfortable with this as our target date for making decisions, and if we're on the right place, then we can look at lifting some of the restrictions. You've got to remember that we are not a shelter-in-place state. We haven't closed all the businesses that some states have, but in Arkansas, the consumers have spoken, and so even though we didn't close some businesses, they closed themselves because people were being cautious and didn't feel comfortable going out. This is about not just giving businesses an opportunity to go back to work and make a living, but it's also about giving the consumers confidence that you can go somewhere and that the right public health measures are in place. That's our objective in balancing that. Arkansans want to work. We need to go to work. Our economy is suffering, but we've got to do it in a way that's consistent with our health guidelines. That's the balance we're trying to achieve. Did you want to address that particular survey?
Yes, so you're talking about the IHME website. I think I addressed that the other day. That was based on at the time point when they expected in their model for Arkansas or any other state to get down to 1 case per million. Well, for Arkansas, with a population of approximately 3 million, that's 3 cases. You know, I wouldn't expect us to wait. First of all, I hope that we are down to 3 cases by June 22nd, but I don't think it's reasonable for us to wait until we're down to 3 cases before we open up aspects of our economy. I mean, we wouldn't close down for 4 cases. So it does. I understand their model and what they've put in place there, but it doesn't completely make sense for a state like Arkansas.
On lifting these restrictions, does that include personal doctor's offices, dentist offices, things of that nature?
We have asked that visits that could wait to wait. I think that after we get to May 4th and we start opening up, I think more of those could occur. We want to do things incrementally so we don't put ourselves at great risk of a resurgence in cases. But I think some of that is a judgment call with the clinicians, and they know their patients and they know how long they can wait.
Is there any concern that this might be too much to open at once? And it kind of, I guess, puts a message out of we're back to normal.
Well, I would point out that we are somewhat in uncharted waters. This is a virus that we've never had experience with in the entire world. So we're using our knowledge of that we've gained in the last few months, as well as all the principles that apply to other communicable diseases. Our approach seems very reasonable. We'll monitor it. Of course, if we see a resurgence of cases, we can always back off. We do have other states that are at different places in the epidemic and are taking different approaches, and we'll also learn from their experience as well. Obviously, if they do the things that we're planning on doing and have a poor outcome, then we'll likely modify our approach.
Negative test.
Just one second. We'll come to you remotely. I wanted to add to that previous question, and it's important to remember, and the public needs to understand this. Even if we're successful and we make the decisions to open up some of these different lift the restrictions on some of these businesses on May 4, even if we do all of that, the phase 1 guideline says that in all of these phases, we're still going to be recommending masks, social distancing, and limitations on gatherings if we're not exempting them on the May 4th directive. And so our life is not going to change in terms of our self-protection and our admonishment that if you're in a vulnerable population, you need to be careful. And so those are going to be consistent through the different phases into the near future, despite the fact that we're looking at ways to lift some of these restrictions so people can make a living. And now to the question remotely.
Yeah, thanks, Governor. It's Stan from NEA Report in Jonesboro. Question for the doctor. It's looking like some of the negative test numbers are going down in certain counties on some days, and I'll give you an example today. Randolph County was down to 206 negative. It actually began at 207 this morning, but there's numerous other examples of that too, of the numbers appearing to trickle down instead of up. How is that possible, and is that a data entry error, or are we seeing something else? Is there an explanation on that?
We're trying to get the results in as quickly as possible, but there's a couple of things that can cause a change. First of all, as we get additional information, we may find that what was initially attributed to one county, because that's where the sample was collected, may actually belong to another county because that's where the individual resided. As an example, we reported yesterday 43 deaths because that 43rd death had occurred in Arkansas, but it turned out when we got additional information that there was actually a Missouri resident. So in the same way, we may find that someone was tested at UAMS, for example, but they actually lived in another county. And so that's how we can move some of those numbers around. We also, initially we had relatively few labs doing this testing, and we had electronic feeds that worked well. As we've had more labs, more different sources, many of those are coming in on fax, and so we don't always have complete data. So it's taking longer to get them in our system and to get all the information into our system. We're working with ways to improve that and increase the timeliness of getting complete information to our database, but as the numbers grow, that's just a challenge.
Over to the right.
Governor, do you anticipate simply any no's on these announcements? And if so, how often could you say simply it's not the right time? If so, how often will you revisit those decisions? Would it be something where you put a time frame, days, weeks, months out?
So the question, I believe, is, do I expect any no's on these announcements? Well, that's the reason you have a decision point, and that is because you can't say right now whether it should be yes or no, and what are the restrictions and guidelines if it is a yes. And so we're going to wait and not prejudge each of these decisions. Obviously, whenever we announce that if we stay on target, if we're successful in our efforts on May 4, we'll be able to lift some of these restrictions. So that is our desire and that is our intent. But we're going to be watching the data every day. We're going to be working with the industry to see what kind of public health requirements and guidelines can be put into place to give the consumers confidence. So we're not prejudging it. We want to be able to open up Arkansas back to business, but we're also going to take it a step at a time and study the data as we move to those decision points.
In terms of that Missouri death, they die in Arkansas, and that's why we were credited with that initially?
That's correct. Is there any other question remotely?
Yes, this is Melissa Zigowick with THV11. My question is regarding antibody testing. We have clinics in Benton and Hot Springs that are currently doing antibody testing with Quest. Is the Department of Health aware of these clinics? And Dr. Smith, has your attitude changed towards antibody testing?
I'm going to let, obviously, Dr. Smith address that since that's who it's mentioned or questioned. But I will say that tomorrow we are going to have more information recommended by our testing advisory group that met yesterday, and we'll have some additional outline for our future in terms of testing. With that, Dr. Smith.
Thank you. The question was on serologic testing or antibody testing. We put out a directive earlier that required that only those that have received a FDA emergency use authorization or have been validated and approved in writing by the Department of Health be used. That's because many of the tests out there are not of good quality and have not proven to be helpful. For the antibody tests that have met those criteria and are being performed in a CLIA-certified lab, which Quest certainly would be, it's important to understand what that test tells, what information that gives, and not to confuse that with the PCR test that we've been doing. An antibody test will tell if someone has been infected in the past, but they're not reliable for diagnosing a current infection. So if someone came in with symptoms of COVID-19, you wouldn't want to use an antibody test for them. You would want to use a PCR test. Now, if someone came in and they said, look, I was sick last month, I never got tested, but I'd like to know whether I had COVID-19, well, an antibody test would be helpful in that setting. A PCR test by now would probably be negative, but an antibody test would be positive. Or if someone said, I've recovered, I know I was infected, but I want to know whether I would be a good candidate to donate convalescent plasma, then we could use an antibody test to see if they've got antibodies, and also we would do a PCR test to make sure they were not shedding virus at that time. So it's a matter of the right tool for the right job. My concern with those antibody tests is that if people are confused by that or they use the wrong tool for the wrong job, they may give someone the impression that they're either not infected when they are, or that they are still infected when they're no longer infected.
One final question.
What's our PPE situation looking like? I mean, obviously, if we're opening up elective procedures, we've got to be in a good place, I assume.
We are. That's why we feel comfortable with it. Also for the May 4 target date, going into phase 1, we feel comfortable with where we are there. Now, that doesn't mean we stop in our procurement efforts. We have a continued path that we have to pursue. Director A.J. Gary is here and works on that every day. We had a shipment come in yesterday, and so as long as those shipments continue to come in, then we feel comfortable with where we are.
Just kind of follow up. So what's the supply look like right now? Is it 30 day, 60 day? Like how much on a best estimate do you think we have?
A.J., do you have an answer to that? For the timeline, do you know, Dr. Smith, the timeline that we have for our PPE right now?
How many days supply PPE?
You better answer that,
Right.
Dr. Smith.
The supply of PPE is really facility dependent. We are supplying hospitals and other facilities, but they are also receiving supplies through their vendors, and those are in some cases being directed by FEMA. So some of the hospitals have got a good supply, others it's not as good, and they'll have to make those assessments when they decide whether to start elective procedures and how many of those procedures to do. I also want to add as well, this weekend we're expecting to receive from FEMA a PPE decontamination unit that will allow us, at least in some cases, for facilities to bring their PPE in for decontamination so it can be reused when appropriate.
Thank you very much.